So in this lecture, I would be concentrating on the recent evidence. So the topic for the talk is fast forward ready for prime time? So in this presentation, I would be talking about the initial, the role of moderately hypofractionated radiotherapy, the UK trials, the Canadian trials, what are the contentions and how hypofractionation has been adopted in clinical practice. And the recent evidence, the main focus of discussion would be the ultra-hypofractionated radiotherapy regimens and our initial experience with ultra-hypofractionated radiotherapy and with few concluding remarks. So we all know the history of hypofractionation is breast cancer is of more than 2 decades. It is the pioneers are from UK, where the STAR trials have established the changed the paradigm for breast cancer radiotherapy, and they have revolutionized the treatment for breast cancer globally. While the UK and the Canadian trials accrued low-risk patients, the more recent trials, that is the import high trials, the Chinese randomized control trial, the RTOG, and the HIPOT trial, which is the Indian study, these studies are accruing patients in involving high risk for recurrence, and because these are the typical patients that we see in our clinical practice. So let us talk briefly about moderately hypofractionated radiotherapy. This is the slide summarizing the UK randomized trials. You can see that the START-A trial maintained the overall treatment time. There was no reduction in the overall treatment time. The fractions were delivered fortnightly, and the dose prescription was 46.1 gray, and the START-B trial was a trial that looked into the reduction in the overall treatment time, and the treatment was reduced from 5 weeks to 3 weeks. As you can see, the mature 10-year results of both the trials have been remarkable. They have proved non-inferiority of both the hypofractionated, moderately hypofractionated regimens compared to standard conventional fractionation. And it is also reassuring to see that there is no increase in the late normal tissue effects with both the regimens. Similarly, the Danish trial also compared, the primary endpoint was not tumor control, it was the difference in the late effects, and the Ontario trial also established and found the same non-inferiority of the moderately hypofractionated radiotherapy compared to standard conventional fractionation. So, however, though these trials have published their results, but there were few concerns regarding few subgroups that were not well represented in these randomized trials, and hence there had been a lag in the adoption of moderate hypofractionation in patients in practice of clinicians who see more of high risk population, and which is the typical case in India as well as in Bangladesh. So what were these contentious issues? We will come to the same one by one. So if you have to talk about the large breast size, there is a concern that hypofractionation, with hypofractionation, the outcome would be adverse. But as you can see from this slide, if you have to look at the radiobiological calculations, if you consider an optimal or the realistic case scenario with alpha beta of 2 for the normal tissues and 3.5 for the tumor, you can see, you can compare the BED is of the hypofractionated radiotherapy, it is lower compared to the conventional fractionation. Similarly, if you have to take the optimistic scenario with normal tissues having alpha beta of 3 and for both late effects as well as tumor, in that scenario also the BED of HFRT is lower. In the worst case scenario also, if you have to see considering alpha beta of 1 gray and 5 gray for tumor, in that scenario as well the hypofractionated radiotherapy has a lower BED. So the large breast size is an independent factor for late effects, but it has nothing to do with hypofractionation. So the key idea is to have a tight control on the dose inhomogeneity. So this was a recent study that was published in large-breasted women, and you can see the grades of toxicity. Hypofractionated radiotherapy has less of grade 2 toxicity, and the same thing if they studied with respect to the posterior separation of more than 25 centimeters. This was also, the same finding was noticed. So what the authors recommended was that you have to definitely restrict the Dmax dose of 107%, but it is not only about 107%, you also look into the lower dose levels, that is the 105% and the 106%. And probably, if it is possible, try to achieve these dose levels to as low as possible. So the bottom line is to achieve a tight control of the dose. So coming to the toxicity, there were concerns about it will be more toxic, and the 5-year data was updated. The 10-year data has also shown convincingly, as you can see from the forest plot, all the with respect to all the toxicities, be it shrinkage, the appearance of the breast, the telangiectasias, the forest plot is in favor of hypofractionated radiotherapy. And if you have to look at the values, the figures in light blue, you can see that the absolute figures are very small, and the difference between the two arms is negligible. And either the normal tissue effects are same or they are fewer. So there isn't any concern, or there shouldn't be any concern of increased toxicity. It's not a real worry. Moreover, reducing the number of fractions also reduces the fatigue. It is resource sparing as well as, and hence it improves access to radiotherapy for breast cancer patients. Coming to the subgroup of patients requiring regional nodal irradiation, and I would like to emphasize here that even the STAR trial had 15% of patients that amounted to around 700 to 800 patients of the entire cohort that had received lymphatic irradiation, and the Chinese trial, which I would be discussing subsequently, also gave hypofractionated radiotherapy to the chest wall as well as the regional lymphatics. So there hasn't been any report of brachial plexopathy, and the shoulder morbidity is also comparable. And in future, we would be also getting the evidence from the lymphatic sub-study, the HYPO trial, and the real trial. The high risk in view of young age or molecular subtypes, these subgroups have been underrepresented, but underrepresentation does not mean that it is contraindicated, and hence most of the guidelines, the ASTRO as well as the ESTRO guidelines do not recommend to distinguish based on these high risk features, and it is hypofractionated radiotherapy is advisable irrespective of these factors. Now coming to the post-mastectomy scenario, this was the Chinese trial that had randomized between conventional fractionation versus hypofractionation, and here the dose per fraction was not 2.67, which was used in the STAR trials, but it was 2.9 gray per fraction, and it was a large trial done in 820 patients, and here RT was given to the chest wall as well as the nodal regions, and as you can see, there isn't any difference in the outcome with respect to the tumor control as well as with respect to skin toxicity and other late effects. The subgroup of patients requiring reconstruction, this is actually not a very common encounter, though in Tata Hospital we do a lot of reconstruction, but overall in the country the same thing would be true in Bangladesh as well. The reconstruction rates are relatively less as compared to the West, and it also depends on what type of reconstruction has been done, whether it is an implant-based reconstruction or autologous reconstruction. So there isn't any randomized data. The studies are still ongoing, but whatever retrospective and prospective data which is available, do hint towards relative safety of moderate hypofractionation for patients with reconstructed breast tissue, because there shouldn't be any biological reason why autologous reconstructed breast tissue should react differently to fractionation changes. And the ongoing trial, one of the trial, which is the ARIA-BR trial, is being done at Tata Memorial Center, and I am the PI on that study. So in due course of time, we should get an answer about fractionation with respect to mastectomy and reconstruction. The another issue is about breast tumor bed boost. So the various trials have studied the boost, incorporation of boost either sequentially or simultaneously, and both in the moderate hypofractionation as well as in the ultra hypofractionated regimen. Because this is a very common scenario in India as well as in Bangladesh, we generally entail giving tumor bed boost to majority of the patients, I would say 90% plus, and hence this is a very valid concern in our practice. So this was the trial, import high trial, that studied the patient-reported outcome as well as the physician-reported outcome, and they compared the results with respect to conventional, with respect to 14-15 followed by sequential boost. And again, there was no significant difference in the two test arms in the patient-reported outcome for toxicity as well as photographic changes. So as I said, the today's standard is moderate hypofractionation, and the uptake has been increasing year by year as we get mature results. Coming to the ultra hypofractionated radiotherapy, the UK FAST trial was the trial that delivered radiotherapy once a week, and the radiotherapy went on for 5 weeks, and in this there was randomization between 50 gray versus 30 gray in 5 fractions and 28.5 gray in 5 fractions, and the primary endpoint was 2-year change in the photographic appearance with several other secondary endpoints. But again, I would like to highlight here that 64% of patients were more than 60 years, 72% entailed SNV or sampling, and very early tumors, which is not like what we see in our country. And when you have to talk about the results of the primary endpoint, you can see that 28.5 gray arm was non-inferior to the 50 gray arm, but that was not the case with 30 gray arm, and hence what is generally practiced is giving 28.5 gray in 5 fractions, and the alpha beta derived from this study was 2.4 gray for the endpoint of photographic change. Similarly, the same findings was noticed in the late effects in the breast, and reassuringly, this regimen also showed a 10-year very low event rate. The 10-year local relapse rate was just 1.3%, which again highlights that this was a very low-risk population that was studied in this trial. Coming to the UK fast forward study, this study again was a 3-arm randomized trial comparing 40 gray in 15 fraction, which is the current standard of care, with 27 gray in 5 fraction and 26 gray in 5 fraction. And here the radiotherapy was given Monday to Friday, 5 days in a week. It was not a weekly fractionation. And here again the primary endpoint was ipsilateral breast tumor control. And again, this was basically 93% patients were BCS, and they were again really early cases. So the acute toxicity, as whether it was measured with respect, assessed according to RTOG or CTCAE, the results were quite favorable. And as you can see, the follow-up of toxicity after completion of radiotherapy, you can see that ultra hypofractionated radiotherapy, the reaction peaked after at 1 or 2 weeks, but it also subsided soon. With respect to the primary endpoint, again, you can see the absolute difference was less than 1%, and the non-inferiority was established, and this was very well welcomed. The study was welcomed because it was during the peak time of the COVID pandemic, and it came into the guidelines also during the pandemic. The late toxicity effect also, you can see that the ones in green, which is the 27 gray in 5 fraction, there was higher concern of late toxicity, but that was not the case with the blue, the figures in blue, which relate to 26 gray in 5 fraction, and most of the toxicities were comparable and not statistically significant. The same thing was noticed with the late toxicity with respect to patient-reported outcome, and the 26 gray in 5 fraction arm was equivalent to the 40 gray in 15 fractions, and the alpha-beta ratio derived from this study was 1.7 gray. So these are the range of all the UK trials that have accrued with different dose fractionation, and the variable, the derivations of alpha beta ratio vary from the endpoint chosen as well as the endpoint with respect to toxicity or tumor control. So one thing, few concerns were raised in the literature, and they said that we really need to wait, and that is actually pragmatic to wait for mature results, 10-year results of the fast and the fast forward. But if you see at how the toxicities progress from 5-year to 10-year, you can see that with long-term, with longer follow-up, the toxicities do develop from 5-year to 10-year, but the relative toxicity difference between the two arms does not change, and hence even as we had seen in moderate hypofractionation, the same findings I expect with the ultra hypofractionated regimens at mature follow-up. So coming briefly to the TMH experience, we had the fast study protocol we do offer, we did continue to offer even after the pandemic, and during the pandemic we had treated many patients, all patients in fact, for 1 year with fast and fast forward fractionation, because patients were locked up in Mumbai, they were unable to go, and there were guidelines also from UK that during the pandemic it was okay to start radiotherapy with fast and fast forward fractionation. So the difference from the West was that large majority of our patients required nodal irradiation, including IMN. Majority of our patients require tumor bed boost, which was given simultaneously, and 50% of our patients were MRM. Higher proportion of patients were HER2 high risk, that is HER2 positive and triple negative. So this was the typical population that we see in our clinical practice. And if you have to look at the toxicity, this is the acute toxicity. And there was only one case of grade 3 toxicity. Majority of the toxicities were grade 2 in the fast forward as well as the fast protocol. So we concluded that with FIF, which was the most common technique used in our patients with tangents, it is very feasible to perform fast and fast forward. It results in mild toxicities. There is no incidence of brachial plexopathy, and the follow-up at 2 weeks was also done post-RT, and hence we know that even after patient went back home after conclusion, there wasn't any worsening of toxicity after completion of radiotherapy, and hence it is safe with respect to the acute toxicities. Now coming to the subgroup of this data, this was the data. This was the study which was done in breast conservation, and we were also interested to capture the cosmetic outcomes. So out of the cohort cohort of 400 patients, we did 377 patients with fast or fast forward, and we did photographic assessment as well as subjective assessment done by the physician as well as the patient, and baseline cosmesis was recorded, and we also recorded cosmesis at up to 2 years. So initially the study was up to 2 years, but now I have extended it to capture long-term data as well at 3 and 5 years. And so here I am presenting only a preliminary analysis because the data is still maturing. Not all patients have completed the assessments. So if you see the baseline cosmesis, which is prior to radiotherapy, 74% patients had excellent to good cosmesis according to the patient, and roughly around the same 80% according to the physician. And if you have to see the cosmetic rates of cosmesis at 6 months, it was 79% according to the patient in the excellent and good category, and according to the physician, it was around 70%. Similar data for 1 year follow-up. You can see the baseline cosmesis 74%. It was 81% at 1 year according to the patient, and 60%. And this is attributed to not all patients. We haven't followed up all the patients, and the follow-up is still ongoing. So this will definitely change at once the full data is analyzed. So what we found in our data was that breast size, the breast tumor ratio, the type of cavity, BCS done outside, I meant to say patients who had incomplete excision and required re-excision at our hospital. So that was one important factor that affected baseline cosmesis, and development of post-operative complications. These were these predicted baseline cosmesis. And on follow-up, what was more important was the if the patient had undergone re-excision, patient is receiving hormone therapy, and breast size with a cutoff of around 700 cc, and breast PTV volume as a continuous variable. These were the factors that impacted even at follow-up. So this was our unpublished data, but I cannot complete the discussion without mentioning this study, which is an Indian study from TMC Kolkata, and it is a multi-center study. And this is the study which we are really looking forward to completion, because this is a non-inferiority trial with 5-year loco-regional recurrence as the primary endpoint. And we do have the early toxicity results from this study, and the findings are exactly same as what we had got in our non-randomized data. Overall, there were only 3 patients that experienced grade 3 radiation dermatitis, and there was no grade 3 or higher toxicity in this early report on acute toxicity. So, and this corresponds, this corroborates with the with our experience. And the figure on the right-hand side, you can see that the very tight dose constraints were followed, and it shows the quality assurance of the trial. And it is very important to have a good quality assurance, especially when you are doing a multi-center trial. So I would like to conclude by saying that hypofractionated radiotherapy has revolutionized adjuvant radiotherapy in breast cancer. Moderate hypofractionation is the gold standard, and mature data from ultra hypofractionated radiotherapy and SIB are awaited, and ultra hypofractionated radiotherapy is likely to win the race by and large, and it is just a matter of time. Thank you.